teams. And I also have the best, what I think is probably the best boss in the world, Dr. Vivian Lee. And she is truly a transformational and inspirational leader for everything that's going on in health sciences up on campus. And I'll tell you a little bit about why I think she's so amazing. So she's coming up on her 4th anniversary at the University of Utah Health Sciences. And she has served as the Senior Vice President and the Dean of the University School of Medicine and the CEO of the University of Utah Healthcare. So what that means is she's responsible for a budget of over $2.4 billion, including a healthcare system that includes our hospital and our clinics, and also Huntsman Hospital and Moran Eye Center. She's in charge of our health plan, our schools of medicine, nursing, pharmacy, College of Health, and our new dentistry school. A little bit about her background. She's not a slouch part. A graduate of Harvard Radcliffe, Dr. Lee received a doctorate in medical engineering at Oxford University as a Rhodes Scholar. Returning to Harvard, she earned her M.D. with honors. Following a residency in diagnostic radiology at Duke, she trained as a fellow in MRI at NYU. Prior to coming to Utah, she served as the inaugural Vice Dean for Science, Senior Vice President, and Chief Scientific Officer at New York University Langone Medical Center. And just personally, I mean, she's just a lovely person to work with, and she has a darling family. Her husband, Benedict, is a professor at our law school, and he also still teaches back at NYU. And she has 4 darling young daughters, so she's got a lot on her plate. So I'd like to introduce you to Dr. Vivian Lee.
You would know, because you all know Vicky so well, how fortunate we feel at the University of Utah to have her as part of our team. She's just phenomenal. Really just phenomenal. I wanted to start by just saying how much respect I have for this organization and the impact that the Rotary Club has had on me personally. And you might even go as far as to say that if it weren't for the Rotary Club, I would be standing here before you. And now you might think, well, how could that possibly be? Well, in order to be the CEO of a health system, you have to be a doctor. And in order to be a doctor, you have to have gone to medical school. And in order to graduate from medical school, you have to have gotten into medical school. And in order to get into medical school, a lot of people will tell you, you have to have gotten through the dreaded organic chemistry class, which never made any sense to me because we never use organic chemistry in medicine. But nonetheless, you have to get through organic chemistry. And in order for me to have gotten through organic chemistry, I needed the textbooks. And guess what scholarship was given to me by the Norman Rotary Club that enabled me to buy those books in my classes. So I'm very grateful to the Rotary Club, and I guess I'm a product of the generosity of people like you. Maybe a little bit different location in Norman, Oklahoma, but same like-minded spirit, and so I'm just really, really grateful. For today, I thought I would share with you and give you a little bit of an update on what's been happening in the health sciences. I didn't realize when I started that Floyd, his second sentence to me was, "How old are you?" I didn't realize that my first slide was actually going to be a little bit of history. So maybe you a little bit, wondering. But if you think back about 50 years ago, there's been actually remarkable transformations in society. So it really wasn't that long ago that we were doing cassette recordings, and we had hair like that, I suppose, and then when gas was around 29 cents a gallon. And it was only about 50 years ago that our medical school actually became housed in its first new home on the health sciences campus. Very much thanks to many of the families that are here or people who you all are connected with very well. And the vision that was presented 50 years ago for this new hospital and medical school was that we would be a center, a hub for academics, a hub for important scientific discoveries, and really the place that we could care for some of the most complicated and sick patients of the entire region. And I think that over the past 50 years, we have at the University of Utah really managed to meet many of those expectations that were set. And I just have a few images and a few highlights. For example, the first neonatal intensive care unit, where those little babies who are so fragile at the beginning of their lives. The first neonatal ICU in the Intermountain West is at the University of Utah. The founder of the dialysis machine, Dr. Kolf, was at the University of Utah and founded our biomedical engineering program. You'll all remember Bill DeVries and Barney Clark and the artificial heart, in that famous Time magazine cover. The large families of Utah, the genealogies contributed to the world's largest database of healthcare and genealogic information, which has been a gold mine, and the source of the discovery of over 35 diseases, the genetic basis of those diseases, like the breast cancer genes, were discovered here, colon cancer, melanoma, and more than 30 others. And Homer Warner, many of you would know Homer and his family. Of course, Steve, who worked at the university for many, many years before being called on his mission, founded the first electronic medical record system in the Department of Biomedical Informatics. Mario Capecchi really developed transgenic mice. And all of those discoveries really have enabled us now to practice medicine at a level that was really unimaginable 50 years ago. The University of Utah, very much unlike New York City where I was before, covers about 10% of the geographic landmass in the United States, our responsibility, our coverage area. And we are the only nationally accredited stroke center, telestroke center. So many of you will know individuals who have had a stroke. In the past, it was a debilitating event. And now with the clotbusters and with telemedicine and the technology that we have set up, we have people who completely recover from stroke without any consequences whatsoever. And we're very proud of the broad span. Here are just some of the dots of the areas that we cover in our telestroke network. Telehealth for burn, telehealth for intensive care unit. We have a fantastic AirMed program. The imaging technology is really unimaginable. We contribute a lot to that at the University of Utah. And then just our facilities like the Huntsman Cancer Institute, being able to take a lot of that family tree genealogical research and translate that into really saving people's lives. Here's an individual, his name is Greg. He comes from a family where almost everyone developed colon cancer in their 30s and 40s, and pretty much everyone died by the time they were 50 in his family. That was because they had the colon cancer gene, APC, and as a result of developing the test to diagnose that genetic disorder, having the family members go through early screening, Greg's now outlived everyone in his grandparents. So these are some of the really terrific advances that have been made over the last 50 years in medicine, some at the University of Utah and others elsewhere, of course. That's the good side of the story. And it really makes you wonder then, well, why are we seeing these kinds of stories in the news all the time, with all the discussion about the Affordable Care Act and the healthcare crisis and so on? And I think the problem is that the advances that we've been making are a little bit uneven. So some things are fantastic. The advances in science and technology are just phenomenal, and we just lead the nation without a doubt. But another way in which we lead, we lead the world without a doubt. Another way in which we also lead, which is not so good, is in our healthcare costs. And here's a slide that just summarizes over the last 50 years the rate of healthcare expenditures compared to wages, and healthcare costs have increased about 50 times faster than wages. So while we've done great in advancing science and technology, we probably haven't done as good of a job in some other areas, like good business practices, many of which you all practice every day in the work that you do. And so what we've been trying to think a lot about at the University of Utah, started by my predecessor, Doris Betts, is how can we keep all the good things and keep pushing those good things forward, but also start to address some of the issues that are really holding us back, including things like cost, like patient satisfaction, like really developing patient-centered care. And so what I thought I'd do in the next maybe 15 minutes or so, and leave some time for questions, is give you a bit of an update on what we're doing in terms of thinking about how to transform healthcare. I always like to start with this slide, especially when I travel out of the state. This is a slide that shows you lots of little circles, and every one of those circles is a different state. So all 50 states are represented on this graph. And on the vertical axis here, we have the healthcare costs per capita. So the healthcare costs per person for each state, and the lowest costs are at the top, the highest costs are at the bottom. On the x-axis, we have the healthiness of the state. The healthiest ones are over here to the right. And so where you really want to be is up here in this upper right-hand corner, where you see that the state of Utah is sort of in a class of its own, where we are the lowest cost in the country, the lowest healthcare cost per capita in the country. And those of you who are trying to bring new businesses to the state, this could be a useful talking point. And I especially like to show this in Boston because they are the most expensive, and they're almost twice our costs, our healthcare costs per capita. And then we're about the 6th or 7th healthiest in the country as well. So when we think about what we're trying to do as a healthcare system, this is what we're trying to achieve. We want to have great health outcomes, healthy population at the lowest possible cost. And we're starting from a very strong position here in Utah. Partly because lifestyles here, people have a healthier lifestyle, much lower smoking and drinking. But also I think partly because our healthcare systems are so strong. The university is strong, our mountain is strong, we do a lot of good work here. And so when we're talking about the transformation, we're talking about it in terms of how do we provide value. In most of other businesses, we think about value for the customers, and in healthcare, we really haven't been talking about it so much. So that's what we want to focus on. How do we provide value, which includes high quality, a great patient experience, and then at reasonable costs. So I have essentially one slide for each of these 3 categories to share with you some of what's been happening in the year. And I hope it'll be a source of pride for you since this is your university hospital. So the first is quality. So every year, all of the university hospitals in the country, there's about 140 university hospitals like Stanford, like Hopkins, like Mayo, UCLA, and so on. And the 140 of us are all ranked in terms of the quality of the care. And the quality of care is measured by how well patients do. So first of all, do they live? That's important. Do they have any kind of complications when they're in hospital? What's the patient experience like? And that's all put together into a scorecard. And the elite group is the group that's in the top 10. When the CEO of our hospital, David Entwistle, joined the University of Utah in 2007, we were comfortably in the middle of the pack. We were about number 50 out of about 100 at the time. And when I was interviewing here, it was in 2010. So I saw this transition from 50, 31 to number 1. And it just knocked my socks off, because in academic medicine, you're talking about a large hospital healthcare system, and then academic type people usually doesn't change very quickly. And the fact that our organization could move from middle of the pack to number 1 in the country in 2 years, unimaginable anywhere else. I was just telling you, this is extremely competitive. We are all looking to get into that top 10. So this was very persuasive in terms of my decision to come here, and is a real reflection of the talent of our leadership in the hospitals and clinics. And then for the last 5 years in a row, we've maintained a position in the top 10. There's only one other medical center, one other medical school in the country that has been in the top 10 for 5 years in a row, and that's Mayo Clinic. And Mayo Clinic has never been number 1. So we're in good company. We're not staying static. There's always more work to be done, but we do feel very strongly that the most important thing that we can do is to provide high quality health care. And we want to be the place that everyone feels comfortable coming to for the best outcomes. The second part of the story is also about the value that we want to provide, and that's really about the patient experience. And something really remarkable to people who are outside of healthcare is how little those of us who are in healthcare think about patients like customers, and how often many traditional health systems are really designed to revolve around the doctor and not around the patient. I don't know if that makes any sense. That's why patients wait for 2 hours for the doctor to show up, right?
And you couldn't really imagine that in a restaurant. You know, I'm sorry, the cook's not going to come, or the waitress didn't show up today, but you just sit in the waiting room for 2 hours. So we're really trying to go through a pretty major mind shift in healthcare. And Loris Betts, my predecessor, started this journey for us at the University of Utah in 2008. In 2008, he just got fed up because he had all these letters of complaint on his desk from patients who were really pretty unhappy with the 8 hours they spend in the ER waiting for somebody to see them, or in the clinic. And then finally, the straw that broke the camel's back was his wife came into the system to be seen by one of the clinics. And you know, her last name is Betts, so it wasn't really like she was a secret shop or anything. And Betts walks in, and they didn't really treat her all that well. And he got an earful, and he said, that's it, I've had enough of this. And so he called, in 2008, he called the senior leadership team together at a retreat at his house, and he said to everyone, we can't be a great medical center if our patients don't think we're great. That's it. And we need to think about creating the exceptional patient experience, not just an okay patient experience, but an exceptional patient experience. And what he set upon doing then with the whole team was really revolutionary. And you may not feel that it's so revolutionary, but in healthcare it was revolutionary. Because what they started doing was asking patients after they left our hospital clinics, what did you think about the care? What did you think about the wait time? Could you understand what the doctors were saying to you when they were talking to you? And they collected all that data, and then not only did they collect the answers to the questions, but they used questions from a national database so that they could benchmark the answers from the national pool of over 100,000 other doctors. Because of course, all doctors think they're great, right? So all my patients love me because I'm the world's greatest doctor. But then we could show them some data, say, yes, you're really great, but 80% of the doctors in the country are better than you are. So we started feeding that information back to the doctors. And then over time, this is what happened with our patient satisfaction scores. So in the red, what I'm showing you here is the percentage of our doctors that when you compare them to the hundreds of thousands of doctors in the country are in the top 1 percentile. So they outperform the other 99% of the doctors in the country in terms of patient satisfaction. And in the orange, it's the percentage of our doctors that are in the top 10 percentile. So you'd expect 1% of your doctors to be in the top 1 percentile and 10% to be in the top 10 percentile. And that's kind of where we were at the beginning of this around 2008. And you'll see that just through Dr. Betts and the whole team giving feedback, we had some SWAT teams that would go around to the clinics and talk to the staff about scheduling and being kind and courteous to patients. And so by the time I started, we were already doing pretty well. We were kind of at this point. And we were already outperforming most of our peers in the country. You could feel the culture was changing. Even when I started, there would be people in the community who would come up to me and say, you know, it used to not be so good at the U, but last time I had a really good visit. So I could sort of feel the tide was turning. And then the chief medical officer came to me, Tom Miller. I don't know if any of you know Dr. Miller, he's fantastic. So Tom Miller came to me and he said, you know, we send out hundreds of thousands of these surveys. And when I'm picking a doctor for my sister or for my mom or for my kid, I would love to have this information on these doctors, right? I mean, you don't buy a toaster oven without looking on Amazon what people thought about it, or pick a hotel without looking at TripAdvisor and see how many stars and what other people said about it, right, or restaurants. So why should you have to pick a doctor without that information? And so he said, I would love to post these patient satisfaction scores and comments online. And I said, really? And he said, yeah. I said, do you have a Kevlar jacket? He said, and so we talked about it for a few months, and then we did it. In December of 2012, we were the first health system in the country to post all of our patient satisfaction scores online. If you go to our website, all hospitals have a Find a Doctor website. If you go to our Find a Doctor website, you look up any of our doctors who have had at least 30 surveys returned, you will see the familiar 5 stars on their webpage. This is Dr. Scaife, one of our general surgeons. And you'll see this is the raw score for what patients evaluated her as. And then if you scroll down the page, you'll see the 10 different questions that we asked, including wait time, including respect, including were you engaged in the decision making. And you can see what she got there. And then if you scroll further down, all the comments. We posted all the comments that the patients have written about them online.
Not only were we the first in the country to do this, but it took the Cleveland Clinic and Duke and Stanford about 2.5 years. They just went online in the last couple of months with this. So we're being recognized now nationally as leaders in this transparency. And I think it's something that we're very proud of, because what's happened with this is that our providers now, this is a real source of pride. So for the last 2 years in a row, half of our providers are in the top 10 percentile of the country, and 25%, 1/4 of our doctors are in the top 1 percentile. They're better than 99% of the other doctors in the country. Oh.
There you go.
So now we have whole clinics like the Madsen Clinic, where every single doctor is in the top 1 percentile. And the patient comments are just incredibly positive. So we're very, very happy. The last area is the cost. And the cost part of healthcare, I think, is really the challenge. How many of you have employees and deal with healthcare costs for your employees rising? Right? So we have about 50,000 employees in health sciences. So I, ironically, on the flip side, also experienced that pretty severely. And in fact, employees of healthcare systems are really high utilizers because it's just so convenient, almost irresistible. So I've experienced that exact same thing negotiating with our own carriers. So, and what we discovered when I started about 3.5 years ago, what I discovered was that there's this dirty little secret of healthcare, which is unlike any other business. In healthcare, we don't really know our costs. So imagine a Ford factory going to the plant manager and saying, how much does it cost you to produce, one of these caravans? How much does it cost you for the wheels or the windshield wiper or whatever? They'd be able to tell you every single fact, right? What would it cost you if we had to shut down a factory for a week? In healthcare, we actually don't know our costs. And when I first started asking about it, I thought it was just a Utah problem. And then I started reading and was kind of assured, although it was also disconcerting, that it's really a national problem. And there's some great articles in the Harvard Business Review, and the New York Times, and the Wall Street Journal by these folks, Bob Kaplan and Mike Porter. Mike Porter is a very well-known strategy guy. Bob Kaplan is a cost accounting, and he's the balanced scorecard guy. And they wrote this quote, which I think summarizes the whole problem. For a field in which high cost is an overarching problem, the absence of accurate cost information in healthcare is nothing short of astounding. If you were to ask most of my counterparts across the country, what does it cost for your doctors to do an appendectomy or to do a cataract surgery, they wouldn't be able to tell you. So we set on a project about 3 years ago to really try to understand our costs. It's kind of a long story, maybe a little too long for right now, but just suffice it to say that we've costed out everything in our healthcare system. We can tell you what it costs for an extra minute in the operating room, an extra minute in the emergency room, an extra minute in the MRI scanner, all of our supplies, all of our labor. And that may not be so interesting to you if you're on the patient side, but if you're on the management side, and you think about how you want to run your business better, it's incredibly helpful. It's actually transformative. And so with this tool, I just summarized one of many, many results that we have, a very similar story over and over again in health sciences. There's this old line, you can't manage what you can't measure. Now that we can measure costs, we can really manage costs. So in this slide, I summarized one of our many projects. This is on total joint replacement. So this is the total hips and total knees. And with this tool that we developed called Value-Driven Outcomes, our doctors can measure quality. So in this graph, this is about 1.5 years of data. In blue, it's the quality measure. So they're always trying to push quality, get the patients better outcomes, no complications. And while they're getting quality up, cost went down by 32% in the last year. And we see this pattern over and over again because when quality goes up, patients don't have complications, they don't come back into the hospital, they don't get infections, they don't have any problems. And so that gets our costs down. It's really kind of common sense. And so what we'd like to do at the University of Utah as a state institution is to be able to start sharing some of these cost savings with people like you in community, because I think that's how we're going to start to solve this. What we're now thinking about, so I've gone over with you how we're talking about this value transformation, and now what we're talking about is how can we continue to advance this transformation. So I'll leave you with a few thoughts about how we're thinking about the future. I think critical to our future are the many elements that are going to be popping up on this slide. Getting the students to practice in a much more forward-looking way, in a quality and cost-conscious way, working with health economists, learning from our global partners, people who are really doing this better in other countries around the world, taking advantage of technologies and new innovations. And one of the opportunities that we have right now is really a once-in-a-lifetime opportunity at the University of Utah, and that is to create a new home for all of this transformation work. This medical school building that I showed you at the very beginning, that was born in 1965, has, unfortunately, they didn't build them as well as they do now, has really outlived its life. And so we have the opportunity to think about and imagine what a new part of campus and a new medical school might look like. And so that's what we've been doing for the last 3 years, imagining what a new part of campus would look like that would take care of populations, really be experts in big data and informatics in that Homer Warner kind of tradition, learn from our global partners and really build on innovation and technology, and really try to imagine a whole new health sciences campus that I think would be better suited and match the kind of aspirations and work that we're trying to do. So we've been working on this for the last 3 years, and I just wanted to give you a little sneak preview. We really haven't started talking about this very much in the community, but thought you might be interested in seeing that while this is what the medical school looks like in 2015, we're looking to build a whole new medical school in the next few years that will include a medical school right adjacent to the hospital, a new rehab hospital, which we're really delighted with. I don't know how many of you have been in one of our rehab rooms. We're always full, impossible to get in there. We turn away about 800 patients a year. So we're going to build out a new rehab hospital and an ambulatory care building. The timeline for this whole project is about 5 years. We will be going to the legislature for support this session, and those of you who are inclined to help us there, we'd be really, really grateful. We think that as the flagship, as the only medical school, as the medical school for the Cougars and for the Utes. So in Southern Utah, we'd have kids from every single college in the state at the University of Utah Medical School. We hope that the legislature can support it. As I said, it is a once-in-a-lifetime opportunity. We're not hoping to do this again too soon. So with that, that's our update from the health science, and I'd be happy to answer questions.
Yes, Dr. Lee, 2 questions on the economics. First of all, the scatter diagram with Utah in the upper right quadrant. That was on a per capita basis. Have you looked at the data on a household or family basis, and does that trend still hold? Household as a household unit. We have a lot of kids in households here, and I'm just wondering if you've looked at the data on a household basis.
No, we haven't looked at it yet, but I reached out to Brent James after I saw that slide, because I said, Brent, we really should write about the Utah story. The former CEO of Mayo Clinic has this great line. He says, we shouldn't look globally outside the U.S. We should all, for the solutions to healthcare, we just need to look at Utah, which is great, right? So I said to Brent, we really should partner together and look at this data and try to understand a little bit better. In part, it is because we are a young state, so the number of children does affect it. But we also, there's another piece of data that I know very clearly, which is one big driver of healthcare costs is end of life. And I came from the institution that I moved from in New York. We were one of the highest end of life costs, and Utah we were the lowest by far. And I believe that that's a big factor. There are social networks. There's really strong family systems, right? People here don't die in the hospital. They care for their families. And in New York, they don't really have any families. So I think there are lots of different contributors. It's not just the youth and the kids, but we actually have a health economist team that's working on it right now. So hopefully I'll be able to answer that.
Yeah, and the second question is regarding the costs and the end of life. Is it true that about 90% of the costs are associated with about 10% of the patients?
Yes, so a significant portion of the costs are due to a small percentage of the patients, concentrated at the end of life, concentrated also in the childhood side, congenital hearts and preemies, the mothers that don't get good care, when they're pregnant. And so we actually have done a lot of analysis in terms of how we can try to concentrate some of our efforts on those patients that are consuming the most resources. One big factor I will just say, since you mentioned this, is there is clearly a higher cost for the patients who are uninsured. The patients who are uninsured tend to use our emergency rooms as their clinics, and they tend to come in after they have their heart attack or their stroke, instead of getting their 10-cent a day pill for their blood pressure. And so that's one of the reasons why we've been very supportive of the governor's Health of Utah plan, just to get more people on insurance so they're not using our ERs as clinics.
How much cost budget cut from the state of Utah, from the legislature?
Our school of medicine budget, about 5%. We're among the lowest in the country. Colorado is pretty low too.
What's the cost of your new medical school and how are you expecting to finance? How much legislature, how much project?
Okay, great question. So the project overall, the building costs are about $350 million. We have some sources of revenue for bonding from the clinical components. We have some philanthropy that's looking very promising on the rehab hospital. For the medical school building itself, it's about a $150 million project. And overall, we're asking $50 million from the state. So it's a $350 million project, and we're asking for $50 million from the state. So that's money that's really being leveraged. And we know it's a lot of money, but on the other hand, it's just a fraction of what the total costs are.
You seem to have done an outstanding job of identifying and controlling your costs at the hospital level. From what I read, the big driver today seems to be the cost of drugs. How can either you or we be involved in helping control that piece of the equation?
Well, the concern about cost of drugs has recently mostly been focused on, for example, the hepatitis drugs, which are very expensive, $1,000 a pill. And, I think that's a really difficult question because the way in which drug discovery is funded now, there's not a lot of incentive for drug companies often to make investments in some of these rare diseases. We were talking about the Cystic Fibrosis Foundation recently, and they have some very expensive drugs. But if they weren't allowed to charge so much, they would never invest in developing those drugs. They would just keep focusing on cholesterol drugs. So it's a little bit of a difficult situation, just the way that, the way the drug discovery process is funded right now. I think we really need to rethink that whole situation because, but just to answer your question more succinctly, on the hepatitis drugs, we're really what they're trying to figure out is which patients are most likely to benefit the most. And if we can do some diagnostic tests first, then maybe we can narrow down those patients who are eligible for taking that drug. But you're absolutely right, that is a huge challenge for us.
Next week, of course, we're going to be at the Tracy Aviary. It starts at what time? 5 o'clock. Dinner starts at 6. By the way, we have a top-notch medical system in Utah. We also have one of the country's finest aviaries, with many improvements which have been done with your Zoo Arts and Parks money over the years. If you haven't been there in the last couple of years, go and find out what a gem this is in the city. Tim will be our host. Thank you, Tim. We're going to donate this book to the Franklin School Library. It's called Stripes of All Types. It's about animals that have stripes and why they do. And Dr. Lee has endorsed that for us. We are adjourned. Thank you.
Good to see you, Jay.